Hi, this is Shane, your respiratory practitioner, again here in our shop in Golden, Colorado, to talk to you today about positive pressure breathing devices. First one we want to talk to you about is a Cpap. This is a Cpap Auto by Rmrr. And what you'll notice about a Cpap, it stands for continuous positive airway pressure. It's a continuous pressure. So when we put it on the patient, wherever we set it, say 10 centimeters of water, that's pressure pushing against the face, against the epiglottis, and keeping the alveolus distended on in-exhalation. Cpap, if you think of it as a Volkswagen, and think of Bipap as a Cadillac, and think of the Trilogy ventilator as a Ferrari, okay? So let's go through these settings so that you can see what's what. First thing I want to show you is the humidifier on this particular Cpap. We replace them with all brand new when they come back to the shop. They're not cleaned and reused, they're brand new. And to put this together, if you're needing oxygen, we have an oxygen bleeder system here that comes right off of the humidifier. This line will connect here and to your oxygen source, your concentrator, and then your circuit will be on top of the humidifier, and it will run to the mask. Now the mask, this is a gel full face mask. This is a gel nasal mask. This is a wisp, very light nasal mask, which is very, very comfortable, pretty new as of the last few years, outstanding. And the last is one of our very best. It's a full face mask, an Rmrr, but instead of coming up over the whole face, it slides down below the nose. You can breathe through the nose or through the mouth, but very, very comfortable and not as binding as the old days. Now you have to keep in mind, binding matters because people are very claustrophobic. If you have obstructive sleep apnea, it's as if I'm showing up at night when you get ready to become unconscious and I'm going to choke you almost to death all night long. So your oxygen level falls down into the 40s and the 50s, and I've seen them even as low as the 30s. I don't know how people sustain life in the 30s other than they've done it day after day, night after night, month after month, year after year for a long time. It's as if somebody has been taking narcotics for a lot of years and their dose would be deadly to anyone else if they were to take that dose. It is a gradual process with this obstructive sleep apnea. It is a weight issue. As you gain weight here, your epiglottis here gets big and beefy, and when you fall asleep or you become unconscious, it slams shut like a large manhole cover that can't be lifted up. And so all night long you're fighting your brain, your parasympathetic system, that fight or flight mechanism to get you moving so hopefully you can reoxygenate. That's where Cpap comes in. We always do it first, not because it's the most effective, but because A, it's the cheapest, and B, Medicare established that guideline a long time ago. If it were me as a 35-year respiratory practitioner, I would not even waste time with Cpap. I would put people directly on Bipap. Bipap is a split level pressure. It's a lot more comfortable. I'll show you what I mean here in a second. So when I turn the Cpap on, it's the long button on top. Now keep in mind we do use several different versions, but they all have an on button. We turn it on, and I put a test long on here so that you can see. Now what you'll notice is this is me simulating the breathing. This is 4 centimeters of pressure, and you can see that this lung is partially distended. This is continuous positive airway pressure. Note that the lung doesn't deflate. It's continuous. A wall of pressure keeps the epiglottis open and keeps the alveolus distended, having oxygenation through the inspiratory phase and the expiratory phase, hopefully preventing these big desaturations. Every time you desaturate, the heart rate goes through the roof, overworking, and the left ventricular enlarges, and it enlarges. And it continues to do so until your heart is 2/3 the normal size of your chest cavity, and you get the diagnosis of congestive heart failure. You start swelling in your feet, and after too long, that fluid has risen all the way up until it's in your lungs, and you can no longer even sleep flat. You have to sleep in a chair, and as you know, the vast majority of all these folks gravitate to a chair because they can't breathe when they lay flat. Okay, Cpap, uncomfortable, but if you get used to it, it helps to push fluid out. If you're a CO2 retaining emphysemic, or say you're morbidly obese and you're not breathing very well at night and you're retaining CO2 because of hypoventilation, this washes CO2 out of your bloodstream. It can help with increased shortness of breath, and it can be used as rescue breathing. In fact, I could put a straw, cut an endotracheal tube in half, fit it here, and allow my patient to sip on it to be able to get a little pressure to help lift that diaphragm. Cpap. It's a Volkswagen, not a Cadillac, but it does work, and it is our first line that we must use with these patients. Let's move to Bipap. And I think of Bipap as a Cadillac because it mimics normal breathing. There's an inspiratory pressure, which we call IPAP, and there's an expiratory pressure, which we call EPAP. The IPAP is a pressure great enough to keep the epiglottis open, and then when the patient starts to exhale, the machine is so sensitive that the pressure drops dramatically to whatever we set the EPAP at. That would be the external pressure keeping the alveolus distended. So we'd have IPAP to keep the airway open, and we'd have what we call PEEP or EPAP at the end to keep the alveolus distended, to keep oxygenation happening even through the expiratory phase. Much more comfortable, much more like normal breathing, not so claustrophobic inducing. So let's turn this one on. Okay? And so what you notice as I look at the screen here to see what the pressure is, this is 8 on the expiratory side. And you can see E, which would be for the EPAP. And as I squeeze the test lung, you can see that it shoots up to 13. So this setting for this BiPAP would be 13 over 8. The IPAP would be 13 centimeters of water, and the EPAP would be 8 centimeters of water. Now, as far as settings, we do sleep studies. We can ramp BiPAP all the way to 30 centimeters of water, and usually we don't go any lower than 5 centimeters on the EPAP. But a patient, depending on how much fluid they're holding, how obese they are, how much activity they have, how big their neck and their epiglottis are, these changes have to be done with a sleep study to make sure that the pressures that we are setting are enough to keep the oxygen level up above 88% all night long. And usually with 1 or 2 sleep studies, we're able to get that. As the patient begins to not be in a sleep-deprived state any longer, which keep in mind, it's almost impossible to lose weight when you're in a sleep-deprived state. And you say, why? We're still exercising. When you're in a sleep-deprived state and at night, your oxygen levels are plummeting into the 30s, the 40s, the 50s, or the 60s. Your heart rate is almost at 200 or even slightly over 200. You are in trauma and at risk of dying in the night because of those factors. You're at risk for a stroke. Because everything in your head in the light of hypoxia tightens greatly. This is where vessels pop. There's a lot of issues that happen with obstructive and central sleep apnea. If we can stop the process and you start exercising and you're no longer in a sleep-deprived state and your parasympathetic system, that fight or flight mechanism, is no longer engaged all the time when you're laying down, all of a sudden you can start losing weight. Everything changes when you're not in a sleep-deprived state. But folks, it is important that we get these patients using these devices. We have to go in. We have to encourage them. If they can't do CPAP after a couple of months, we need to switch them to BiPAP. But we need to stay on them because it's really hard for the population that we work with, which is mostly seniors, when they have other comorbidities, other issues going on. If sleep depravity is one, it's almost impossible to get over all the other issues until we address the sleep depravity issue. We need to get them into REM sleep. We need to get their heart repolarizing all night long instead of overworking all night long. We get this fixed. It is the key to getting all the other medical issues under control. So keep that in mind and keep encouraging your patients. Now, let's move to the Trilogy, which happens to be one of my favorites. Now we have my favorite, the Trilogy ventilator. It's not my favorite because it's so expensive. That part of it I do not like. What I do like though is it has a lot of good alarms. So we'll silence the alarm. What it does have for us is a setting called AVAPS. It is an auto variable pressure to the airway on a breath-by-breath basis. We have it already in BiPAP with AVAPS. And so on a breath-by-breath basis, the IPAP and the EPAP can adjust to whatever the patient needs. I like the Trilogy because it's way more robust than a CPAP or a BiPAP. What I really like about it is it has all the same critical care settings that any ventilator in any intensive care unit in the United States has. So if we have a patient that we're doing non-invasive using a mask, the same way we would on a Cpap or a Bipap, it works exactly the same. You're going to turn it on. We'll already have everything set for you. We set them here in the shop per the orders from the physician at the hospital. Most of the time they will call and contact me. We discuss settings, where we're going to go. So we do have a lot of great communication there. I would encourage you guys to do the same kind of communication. The more communication that you have with the facility, with the hospital, the better the patient's going to do, the more knowledge that we can gain, the more prepared we are when the patient shows up. And what we want to do is always have the room set up so that when the patient and family get there, everything is ready to go. It looks professional, it makes everybody feel at ease, and if the patient gets there and gets in trouble, which a lot of times they do, just from the movement in the ambulance from the hospital to us, they need care right away. Respiratory issues arise. We have everything there ready to go. We have no emergency, we have no issue. Remember, don't ever panic, okay? Patient sees you panic, guess what they do? They panic. We don't panic no matter what. Endotracheal tube comes out, no panic, we're just going to put it back. Tracheostomy tube comes out, no panic, we're just going to put it back, right? Take a deep breath and keep going. All right. Now, what you notice with this ventilator is look how distended my test lung is. Now what I can do is go into the settings and I can change the modality. Okay? And so I'm going to put it on AVAPs. Okay? Finish it. Now everything on the ventilator, you have to have two commands in order to initiate the order. Okay? So everything, and what you notice is it's just smooth on a breath-by-breath basis. If I get stricter, it'll require more pressure. And the beautiful thing about the Trilogy is it is a sophisticated ventilator. It's easy for the family to use, so if the patient goes home, this can go home with them. We can train the family about all the modalities, all the alarms, and it's mostly going to be the alarms. The family's not going to be changing the modalities unless we put two settings in here, which we can. We can have two prescriptions. So one when they're weaning or awake during the daytime, and another more controlled setting when they're sleeping. But this is the beauty of the Trilogy. It's an expensive machine, but we're seeing a lot more Trilogies because we're treating end-stage emphysema a lot with them for rescue breathing. Again, I can cut an endotracheal tube in half, put it here, and my emphysemic patient who has no diaphragmatic strength at all is able to sip and puff all day long on the ventilator to help them breathe. So that's a great aspect. But mostly what we're doing is we're treating ALS in some of our facilities through their trach. Their cuffs are up. Truly we are rescue breathing for them. We are basically ventilating and oxygenating them because they can't breathe on their own. As you know, ALS is a paralyzing disease. So we have a lot of patients that are invasive through the Trilogy. It works very, very well. And again, it's not a really big booming box that everybody's afraid of when they go into the intensive care. It is truly, though, a ventilator. It is a very nice piece of equipment that we are now bringing into the SNFs. And if you guys have any questions, you want demonstrations, you want us to come in and to do some critical care training so that your facility can take and manage these patients, we will do it. Call me directly at 303-507-1565 or reach out to us at RockyMountainRespiratory.com. Thanks so much for taking the time to watch this video.